Okay, let's talk about the drugs in obstetrics. Okay, irons. First things, irons. There is a daily iron requirement in the first trimester is 0.8 mg per day. In second trimester is 4 mg per day. In third trimester 6 mg per day. It's the daily iron requirement. The iron deficiency anemia, you have to classify the anemia based on the severity of level of hemoglobin. If it is 10 to 10.9, mild anemia is 7 to 9.9 is moderate, severe is 4 to 6.9, less than 4 is less than 4 is very severe anemia as per ICMR classification of the anemia. Iron, there is oral iron preparations. First one is ferrous sulfate. Ferrous sulfate most commonly use oral iron preparations. The tablet is 200 mg tablet with 60 mg elementary iron anhydrous. Daily dose iron deficiency anemia have to give you 180 mg, so you have to give a 3 tablet. Also available also solution syrups. Anhydrous form is better. Advantage is cheap, good viability. Disadvantage of oral iron preparation is very important is nausea and vomiting and abdominal discomfort and poor compliance. Though iron ferrous sulfate traditional oral formulas, these are the formulations. Okay. Then diagnosis of iron deficiency anemia in pregnancy can based on the MCV RDW. There is low MCV, low MCH, but up to 40% pregnant women with true iron deficiency have a normal citing indices. Combination low MCV accompanied elevated RD2 can be used to sufficient evidence to start therapy. RDW decrease in thalassemia patient. Serum iron TIBC is a unreliable markers. Serum iron so diurnal variation is affected by dietary influences. Pregnancy itself increased total iron binding capacity in the absence of iron deficiency anemia. The diagnosis of iron deficiency anemia in pregnancy based on the serum ferritin cut of 30 microgram per DL to diagnose and treat iron deficiency anemia in pregnancy. Indication to testing serum ferritin in pregnancy prior to start iron therapy in therapeutic dose in patient with known hemoglobinopathy. When an alternate etiology microcytic anemia is being considered, chronic inflammation lead toxicity sideroblastic anemia. Suboptimal response to oral iron therapy when compliance is doubtful in non-anemic women at increased risk of iron depletion such as those with previous anemia, multiple pregnancy, teenage pregnancy, high risk bleeding, consecutive pregnancy less than 1 year, 8 weeks therapeutic iron therapy, iron deficiency being treated, serum ferritin is still less than 30 without anemia. Preferably, iron supplementation in pregnancy. WHO recommended is daily iron and folic acid supplementations. 30 to 60 mg of elementary iron, 400.4 mg folic acid is 400 microgram recommended for the pregnant women to prevent maternal anemia, puerperal sepsis, low birth weight, preterm birth. If woman diagnosed with anemia during pregnancy, her daily iron should be 120 mg until her hemoglobin to be normal, like 11 gram per deciliter or higher. In Fox GC per 2017, pregnant with established mild to moderate anemia with a period of gestation less than 30 to 32 weeks. Those who respond to a trial to oral iron treatment should be continued with 100 mg millimeter iron twice daily and 500 mg microgram folic acid. After achieving the normalization of the hemoglobin, prophylactic iron supplementation is changed to 1600 mg. 500 is recommended for at least 6 months during pregnancy. Should be continued postpartum for another 6 months. These are the oral iron preparation already told. Oral supplementation with the type of preparations. So all pregnant should be instead to take oral iron empty stomach or iron empty stomach or 1 hour after meal for better absorption prepared with vitamin C rich products such as orange juice or guava. Remember orange juice or guava. Oral iron therapy assess response rising 1 gram per deciliter is expected at the end of the 2 weeks by 2 grams daily deciliter by the end of 4 weeks. 2 weeks in 2 weeks 1 gram, 4 weeks 2 gram increase. GI side effect already told 70% ferrous sulfate, 20% over respective. Parental iron, iron sucrose 200 mg per day in 100 ml NS over 20 minutes alternate day, 3 days for a week, maximum 600 mg per week. Ferrous carb FCM not approved to be given in pregnancy but can be given in second and third trimester. FCM can be given in second and third trimester. 20 mg per kg infused over 15 minutes. Maximum 1 gram, that is 1000 mg per day. Ganjoni formula to calculate the total dose iron to be given. Total deficit 2.21 into 40 or 11 or actual hemoglobin into pre-pregnancy body weight plus 1000 is the deficit or the maintenance that iron dose to be calculated. The indication of the parental iron therapy: poor compliance to oral irons or intolerance to oral irons or malabsorption syndromes. Response to iron therapy: what are the response? Initially 12 to 24 hours, irritability, increase appetite, decrease irritability. Fast response is decrease irritability and appetite will improve. 36 to 48 hour initial bone marrow response, erythroid hyperplasia 36 to 48, 48 to 72 hour reticulocytosis, peak at 5 to 7 days, 4 to 30 days increase in hemoglobin level, 1 to 3 month repletion stores. Parental iron 3 indication: failure to oral therapy, non-compliance, intolerance, last second third trimester moderate to severe IDA, malabsorption syndrome, bleeding diathesis, hemorrhage likely to continue. Combination erythropoietin in pregnancy, chronic disease, moderate to severe postpartum anemia with compliance to oral iron, follow-up to be health facility doubtful. Contraindication like a known case of history of anaphylactic reaction to parental iron, gestation less than 12 weeks, it should not be given. Known state of iron overload. Various studies shown that once indicated intravenous iron 3 is superior to oral iron 3 in terms of speed, absolute extent of hemoglobin increase. The parental iron's preparation: type 1, type 2 complex, and type 3. Type 1 is strong, moderate, strong, weak. Type 1: in type 1 FCM iron isomaltose, peroxy iron dextran, iron sucrase is type 2 complex, perox iron citrate, iron sorbitol. Properties: all these properties, iron dextrans and sucrose, you can read. Methods of administration: already I told, intravenous undiluted. Steroid injection on an extreme. Pericarditis type 1, not a steroid external, induced hypersensitivity can be administered at higher doses. Short infusion times, minimum 50 minutes. Iron release slowly, avoid toxicity, oxidative stress, structure similar to peritin, deposit easily, reticular endothelial cells. A test dose is not required, low immunoglobulin potentials, immunogenic. IV sucrose injections is contraindication, known hypersensitive reaction to iron sucrose of any excessive anemia not attributed to iron deficiency. Iron overload or disturbance circulation. A patient with history of asthma, eczema, other atopic allergy because they are more susceptible to extensive allergic reaction. Pregnancy in past times, so it should be contraindicated FCM injection or iron sucrose. The advantage of FCM, safe options at higher dose you can give 100 mg elemental iron, Fe2 plus in FCM against 200 mg elemental sucrose in single infusion. Few clinical visits you require for iron carboxy maltose. Unlike iron sucrose, multiple PC total dose infusion like 5 days, alternative to 10 days. Near neutral pH physiological osmolarity and low rate of injection site reaction, overcome low dose in limitation. Type 1 dextran free robust iron with long half life, stable complex, doesn't release non-transferred iron. Structure is similar to ferritin, deposit easily in reticular endothelial state, no antigenicity, low antigenicity, no test doses required. Very, very important for FCM injections. It is a low doses limitation. So type 1 dextran free robust iron with long half life. Stable complex will form, structure similar to ferritin, easily deposit in reticular endothelial, low antigenicity, no test dose required. Folic acid 400 microgram per day. Folic acid low risk with no comorbidity. Prior history of NTD 400 microgram per day. Moderate is 1 mg per day. Maternal comorbidity 1 mg. High risk previous history of a neural tube defect 4 mg per day. National Iron Initiative pregnant women 100 mg elemental iron, 500 mg folic acid for 100 days after first trimester, from 14 to 16 to be repeated 100 days postpartum. Calcium RD raised daily requirement to 1200 mg per day. Role of decrease hypertension, preeclampsia, decrease hypertension, preeclampsia, low birth weight, chronic hypertensions. Calcium supplement, carbonate, citrate, gluconate, lactate, induction, PPH agent, dinoprostone gels, mifepristone, oxytocin, methoxin, carfos, misoprostol, and tranexamic acid. This is the dinoprostone gels, Servipine gels, 0.5 mg. It is come as it is the route is intracervical dose is already it is a pre-filled syringe. Okay, 0.5 mg in 2.5 ml gels every 6 hour, maximum 3 dose in a 24 hour. Cautions oxytocin to be started 6 hour after the last dose and the store at 2 to 8 degrees centigrade. Cervical uses: it can be used for cervical ripening, reduce failure of inductions, reduce need of oxytocin, shorten the induction delivery interval. Another thing is dinoprostone pessary 10 mg. This vaginal use only. Dinoprostone pessary is intravaginal insert in posterior fornix 10 mg. The release is 0.3 gram per hour at 0.3 mg per hour. Duration is 12 to 24 hour or until active level starts. At ARM augmentation with oxytocin to be done as soon as it's removed. Very, very important. The difference is dinoprostone gels and dinoprostone pessary. So for the gel you have to wait for 6 hours, but in dinoprostone pessary after it's as soon as it's removed you can start oxytocin augmentation ARM. Drawback is very, very expensive to be maintained in cold chain, is minus 8 degrees centigrade. Then mifepristone RU486 is the antiprogesterone prime myometrium, cervix for prostaglandin axons. Antiprogesterons. It can be used for MTP, emergency antiprogesterone primes myometrium and cervix for prostaglandin axons. It causes priming. It causes priming for the action of the prostaglandin. priming the myometer and the cervix for the axle and prostaglandin. Use per MTP emergency contraception IPC 600 mg within 72 hours. Induction is in 200 mg per day for 2 consecutive days. Viva breast gynecological use endometriosis leiomyoma 25 to 50 mg per day leiomyoma, and endometriosis 100 mg per day for 3 months. Viva breast endometriosis and leiomyoma gynecologically use this. Contraindication long term systemic corticosteroid intake like contraindication like adrenal failure, glucocorticoid antagonist, mifepristons. MTP emergency contraception, IOL. Then uterotonic oxytocin is 10 to 40 units in 1 liter normal signs, or lactate drink or lactate solution 10 units, continuous frequency, avoid undiluted rapid IV infusion because hypertension. Methergine 0.2 mg every 2 to 4 hours, avoid if patient is hypertensive. Post to avoid asthmatic patient will continuation hepatic renal cardiac diarrhea fever tachycardia patients, and Vijabristol 800 to 1000 rectally. Oxytocin IV infusion 5 unit in 500 ml, 5 unit in 500 ml in as per RL, or 10 unit concentration in 10 ml in as per unit. Regimen SCOG. Low dose and high dose regimen, starting dose 0.5 to 1.5 milli into internal per minute. Interval is 15 to 40 minutes, or you can start high dose 4 to 5 minutes. Start storage is 2 to 8 degrees Celsius. Routes is IV, IM, buccal, and nasal. Oxytocin active management after labor is 10 unit IM and within 1 minute of delivery of the baby. 5 units in 5 ml NS OAV over 5 seconds. 10 units in 500 ml